Today, I actually discussed 5 different trials, 2 colorectal studies and 3 hepatobiliary studies. The 2 colorectal studies were earlier phase trials, one of which was using an ADC that targeted CEACAM5 with an exatecan payload. The second of which was an early phase trial looking at 5 different drugs with a modified FOLFOX background and bevacizumab with a PD-1 inhibitor and a novel adenosine antagonist. The 3 hepatobiliary trials that I covered, one was in pancreatic cancer called the Giant trial, which was looking specifically at an elderly and frail population of patients, those that were considered vulnerable, and using 2 relatively standard drugs, combinations, 5-FU liposomal irinotecan and gemcitabine nab-paclitaxel. The cholangiocarcinoma trial looked at adding SBRT to systemic chemotherapy with gemcitabine and cisplatin. And the last trial was in hepatocellular carcinoma using ipi/nivo versus TKI in the first-line setting in unresectable HCC. The median progression-free survival was 6.6 months. So, of course, this was a single-arm trial in a heavily pretreated population with about 80% of patients having already received 3 or more lines of therapy. The safety was actually relatively tolerated. What we expected to see is what we saw, which was the majority of patients actually experienced neutropenia. What we didn't see in other trials that have been used with a similar target, for example, in non-small cell lung cancer, which is actually interstitial lung disease or ocular toxicities that had been previously reported. So, the bystander effect is important because you don't only kill cells that express the specific protein of interest, so in this case, CEACAM5. However, you can also impact cells that aren't necessarily targeted by the antibody if for whatever reason those cells lack the actual protein of interest, or if for whatever reason there's just a very low expression on specific subsets of cells there we see a high expression in others. The ADC can bind, be internalized. The cell is then subjected to the cytotoxic agent. And then actually when the cells die, that cytotoxic agent is also released into the local environment and so continues to kill cells. So again, it's not just the impact of the ADC itself, but the added effect of the bystander effect. Well, that's the thing actually about the Giant study. There wasn't really much a difference between the efficacy and safety of the 2 arms. They were both shown to be equally efficacious, although the median overall survival was lower than what was expected for the population in both groups. And the safety just showed that it was relatively tolerated once patients were able to actually get onto and continue therapy. More of the issue is that these patients, being vulnerable to begin with, is that unfortunately a large portion of them, maybe even up to 30%, didn't even make it to study or only received 1 dose of treatment, and 40% of patients actually stopped the study prior to the first scan. Unfortunately, adding SBRT did not improve upon systemic chemotherapy as we had expected based on some earlier trials like SWOG 0809, where at least in the adjuvant setting we had seen some improvements by using radiation. I think that part of the reason for that, though, is that the tumors overall were just larger in the radiation arm. So, even though it wasn't statistically significantly different, the upward range of the tumors that were being treated with SBRT was 10.5 centimeters, compared to like 6 or 7 in the control arm. What we did see, though, was an improvement in local control, which is not surprising, but also there was preservation of liver function, and likely that's because you had local control of the tumor, and so you weren't seeing degradation of the liver function just from growth and expansion of the tumor itself. The difference between the median overall survival was about 3 months, favoring the ipi/nivo arm. What I would do, though, to keep this in context is the fact that it was still both arms were relatively toxic, and there was about a 40% rate of all grades of treatment-related adverse events in the ipi-nivo arm. Even though we technically talk about immunotherapy being easier to tolerate than pills, which patients I think frequently mistake for also being easy to tolerate just because they're oral therapies. Combination immunotherapy has to be taken seriously in regards to adverse events. We also have to keep in mind that we don't want to compromise efficacy by doing things like giving flip dose treatment. So, for example, giving instead IPI-1 and Nivo-3, because in studies looking at it in the second line setting, like Checkmate 040, we actually didn't show that that was any better or didn't show any statistically significant improvement over single agent immunotherapy alone with nivolumab.